I think maybe we should start. Good afternoon. Welcome to monthly Medifase Research Seminar. It's my great pleasure to introduce Dr. Zhongwei Zhou from Johns Hopkins. Dr. Zhou is assistant research scientist in the Department of Computer Science at Johns Hopkins University. He received his PhD on biomedical informatics from Arizona State University. So his research focuses on the development of novel AI method to reduce the annotation effort for computer-aided diagnosis and detections. So he received many prestigious awards, including AMI, a doctorate dissertation award in 2022, and Medical Image Analysis Best Award in 2020, and also Mickey Young Scientist Award in 2019. So he has over 15,000 Google citation, and one of his paper on the ULANT++ image citation received over 8,600 citations. So he was also named the top 2 of the scientists released by Stanford University in 2020 to 2024. So please join me in welcome Dr. Zhou. Today he will discuss body mapping towards a personalized 3D atlas of the human bodies. Thank you.
Thanks for the kind introduction. It's my honor to present my work here. So I will start with the 2 very exciting news at Hopkins. First is we try to build the data science and AI trust database. And this initiative is to let Hopkins to be the primary medical data set provider for the public domain. And people can train and test the AI algorithm on top of it. And our group's work is very related to this initiative. We try to create the largest CT scan database in the world and make other people be able to access and train test. Another one is even more recent is the booster for cancer moonshot. And here, the Hopkins essentially want to detect the cancer early and treat the cancer better using the surgical plan. And these 2 news are all very exciting, which university doesn't want to do that. And our group, of course, the research goal is not that big. We are mainly focused on the CT scan, abdominal CT, and try to detect the cancer in the abdominal region. So today I will introduce the BodyMax project, which includes the AI integrated annotated database creation and the AI assistant cancer moonshot. We try to use this database to solve the clinical problem. And lastly, I will introduce the AI trust benchmark. We invite the AI inventor around the world to see which AI is the real state of the art or which group do the best job on that. So a little bit of background and motivation about the BodyMaps project. Based on the name, you might find it's similar to Google Map, and the idea is very similar. So to understand the Earth, the Google did a very good job to have a satellite image, but this image may not be very useful in the daily life because it's not annotated. And here, what I mean by annotation is to annotate where is the mountain, where's the strait, where's the university. And then they try to map this information into the knowledge so the people can understand what is going on real time. And based on this knowledge, a whole lot of apps can be introduced. Similar things in the medical image analysis. We find the raw CT data is not very useful for the majority of the population because when I first do this field, I have no idea what is this. So same for AI. If you want to train AI on the raw image, it might not be very helpful. And people try to annotate them, but this annotation is way more complicated and require more expert knowledge than annotating natural image because we found only medical trainee or medical expert can do this kind of task, and it's very expensive. And once you fully annotate a patient, you can extract the knowledge, so what's really going on inside this body. and eventually many exciting application can be made. And here, one example is a VR, AR device. So not only the radiologist can benefit from this map, also the patient or the educator can understand the human anatomy better. Google Map tried to map the Earth, and we try to map the human body. And here the Earth, we only have one Earth, but here we want to create a body map for each individual human. That's a very classic project a long time ago, last century, called the Visible Human Project. And they used the real human, and they cut them into pieces, and they save it for the analyze and visualization, what is really going on within the human. And this project has been very successful and very useful for the education and visualization. The limitation is they only provide two persons, one male, one female. It is not personalized. So, they only provide the dead body, and the real patient may not be similar to the dead body in the clinical. So the good thing is we have a CT scan or we have an MRI scan. We can make a three-dimensional image of to understand what is going on inside human, and this is a personalized. That's the motivation we try to use the CT or MRI to build this body map that can benefit each individual. The idea is pretty simple. Give a raw data, not very useful, maybe understandable for a very small proportion of the expertise. We try to annotate it and make it information, and later on make it a knowledge and application. We did this. We asked radiologists to really annotate each pixel in the human and help AI algorithm to do a good work when new patient is coming. So this is a very, very time consuming. For one color is one anatomical structure. Usually take a radiologist to sit there in front of computer, 30 to 60 minutes to finish one annotation of each anatomical structure. And the problem is that this is not even their daily work. Their daily work is to treat the patient, not to annotate the medical data for AI development. So this strategy is widely adopted in the medical image analysis, AI-based, but we found it's very, very inefficient. And the time cost will even increase if the anatomic structure is very complicated. For the liver or some big organ, it might take 1 hour. But for the colon, it can take up to 3 hours to finish this. And we find that the public available databases not really did a very accurate human annotation. So this also raises a problem. Due to this very expensive nature of annotation, we found that the public available abdominal CT database is very small. So those are the very classic database, usually a few hundred patient CT. And the recent database become larger, few thousand, but some of them are not annotated, the pure raw CT data, and some of them are annotated a very small proportion of the anatomical structure. So our first contribution is to build a really big database, which is public available. We call it Abdomen Atlas. It's we already published 1.0 and 1.1, but internally we currently have 25,000 CT volume, which is 25,000 patients, 12 million CT scan. And these CT scans are all annotated. It's about 600,000 annotation mask. And we annotate 135 body composition, anatomical structure. And this CT scans very diverse. The patient population very diverse, collect from more than 100 hospitals worldwide from 19 different countries. So this is the screenshot. What's the anatomical structure we have been annotated so far? And here is the distribution, how our data set look like in terms of the human patient demographic feature and the diagnostic feature and the tumor size and other things, other metadata. So it's It can be all analyzed very precisely. So guess how long it will take if you use the conventional method to annotate 25,000 CT images and 600K 3D masks. We did a rough estimation. It will take a radiologist from 1790 if he want to finish the annotation of building this huge database. And this is the time when DC becomes the capital. It's clearly not possible to use this. That's why we try to propose some smarter way to annotate this database. And by the way, the annotation is really, really important to train the AI algorithm. So that's why it's difficult, but people still want to do this. So the first topic we want to propose the AI integrated annotation. Two products we provide. One is a scalable medical AI platform that can help you to annotate the normal anatomical structure. And the factor of the speed up can be more than 500 times. Second strategy is to use a synthetic data engine because mostly the cancer CT scan is much more difficult to collect compared with the normal CT scan. And especially in the early stage, the small cancer, it's very difficult to find. And that's why the synthetic data can be very useful to help AI to quickly get a good performance and help you to train, to annotate this cancer scan. And we found it can boost the speed by 15 times compared with a conventional method. This is an overview of the scalable medical AI platform. And the idea is very, very similar to the Scale AI company. We try to accelerate the development of a trusted data set and AI algorithm. And don't be really frustrated by all these details. So today I will only focus on very important part of this. So an overview, first you have a clinical need and you have the very huge raw data repository from clinical side or from research side. So we need a retriever to find the data that the patient we really care about. For example, we care about a pancreatic tumor, patient with pancreatic tumor, especially in the early stage. Conventionally, people use the keyword search, but here we try to use the vision language model to speed this up. And because the keyword search, you cannot say, I want the early stage tumor patient. It's not work like that. So here, the vision language model can really do a good job. And after you curate this small proportion of the database that's suitable for your research, we try to annotate them because this database is raw data. It's not really useful for training AI. So now we propose some sort of a human in the loop pipeline. So we do not want the human annotator to annotate each one of the patient because we found some patients, the scan might be easier to annotate and some are very difficult. And a different scan may contribute differently to the AI training. So we want to have some smart pipeline that can find the most significant data to boost the AI the best. So here we propose two methods. One is called label expert. Another is a test on training strategy. So we know now that AI can do pretty good job to give you some pseudo label if you have unannotated data. And the difficult part is to find an automatic way to get the noisy label from this pseudo label. One strategy is to test on the training. So you train this AI and test on the same data set. And this data set is not well annotated, it's the pseudo annotated. And you will find some data point, the loss decrease very well, and some, the loss can never decrease. This is a good signal that this data might have a very bad annotation because AI is really good at overfit. If it cannot overfit one data point, most likely this data point annotation have some issue. And we use this method to find 90% of the noisy label. It's very effective. And the second strategy we call the label expert. Because the assumption is we found that the current large language vision language model is really good at doing some task easy that can be done by high school student. So if we can teach the model, we don't need to fine tune this model because this usually provided by some big company and it's already very strong. So we try not to touch anything about this model. We just prompt. We tell the model what the certain anatomical structure should look like in the CT scan and give two candidate of the label produced by some AI algorithm and ask the model, which one you think is a better quality. And this kind of strategy is extremely accurate in comparing the quality of the pseudo label. And this method can work 24/7. It's very fast. And if you want the human to do it, it can also do this work, but it's pretty slow, 5 seconds per scan. But the large language model can do it 35 million pair of comparison within 1 or 2 days. So these two, the test on training and the label expert can quickly find the label error in your first version of the database. And also it can find the label error in the public available database because when the data scale become bigger, you need to be really careful their data, their label annotation might not be good. So here's one example from Total Segmentator. It's a very popular database for multiple structure segmentation. And if you really look into each instance segmentation, this is the ground truth they provide is not very accurate. And using our proposed method, it can quickly find this error, and we can only send this error to the human expert for revision. So this can dramatically improve the efficiency. So far I talk about the normal anatomical structure, but our real goal is to be able to annotate the tumor in the human body. And the tumor annotation is a whole different story compared with the anatomical structure annotation. Because the structure annotation, to be honest, the medical training or someone like me, CS people, I look at 10 or more example, I can do it myself. But the tumor annotation is pretty difficult. So far, I have been working on pancreatic tumor detection for 5 years. Still, I don't get it where it's some small tumor will be. So it's extremely difficult. So we move on to the tumor detect annotation, per voxel annotation. And I first present the result. We produce this database, have 9,000 patients, and we annotate all the tumors in the liver, pancreas, and kidney in these patients. And we also have the normal as the control. And in total, we have 8,000 tumor 3D mask. And this database is much bigger than existing public available dataset, especially for the tumor dataset. For example, the liver tumor is only have a 200 scan for training. Pancreas, kidney only, all have this small number of patients. And this database will be really soon. And we already actually share with multiple research group internally to give us some feedback and beta test. Now I will talk about how to build this tumor annotated dataset. There are two secret weapons. First is the synthetic data. The second is RC analysis. So I will first briefly introduce the synthetic data. This is a very hot topic in the natural image generation. Probably you already use a lot of products online, the Midjourney and GPT. And this is an old example. We found this kind of generative AI can generate something reasonable, but never happen in the daily life. And this makes us to think, what about medical image? Can this model generate reasonable CT scan? The answer is not. So we have two prompts. We want the CT with liver tumor. We want a CT without a liver tumor. You can see I'm not sure if you are familiar with the CT, but to me, they are very, very different from what the CT is supposed to look like. But synthetic data is very promising. I think it's a good research topic because it's cheap. And if you can generate the data based on your controlled mask, these data and annotation are perfectly aligned. So you won't have any label noise issue. And the medical data is very sensitive. If you have a synthetic data, which is useful for AI training, you don't need to worry about the privacy issue. And if you can make this generative AI work, you can essentially generate enormous amount of training data for AI and never bother radiologists to do the annotation for you. It have other good property if you study synthetic data, but I will not cover this in this talk. So our team at Johns Hopkins have been working on this topic since 2022. And we are among the first team that can demonstrate the usefulness of synthetic tumor in cancer research. There are, of course, many other related work. Last year, the NVIDIA have some generative AI that can generate the human body pretty nicely, but their ability to generate tumor is limited. So our team so far can generate a pretty nice tumor in the CT scan. But here I want to declare all the CT here is a real CT, only the tumor area and its surrounding is generated. So it's different from what NVIDIA is doing. So why we can make this generative AI work? That's an observation. We are more focused on the early stage tumor because when it's too late, first, it's very difficult to synthesize because the later stage tumor, they're very complicated in the texture and complicated in interaction with the surrounding neighborhood, the vessel and everything. And if you have a AI to detect a late stage tumor, it's not really useful. And according to our study, AI detection rate for the late stage tumor is already very high. It's nearly perfect because it's so visible. The real problem is the early stage tumor. So we find that early stage tumor is actually looks similar in CT scan across the solid organ. For example, here are 4 examples of a real tumor in the pancreas, in the liver, in the kidney. You see at the early stage, they look like a noise, small noise, and it's a bit dark compared with the normal tissue. Based on this observation, we proposed a generative model to overfit the small tumor appearance. So here I use the overfit. Usually, it's a bad word in the AI because you try to generate something you already know. But in this scenario, overfit is a good thing because all the tumor at the early stage look very similar. That means if you can overfit the liver tumor, you can probably generate very good early stage tumor in other organs. So essentially, we try to translate this disadvantage of overfit into an advantage that can generate many, many early stage tumor. To support our observation that tumor in across the organ looks similar at early stage, we did some serious study. So first, we mix them up, different early tumor in the different organ. And we try to ask a radiologist to tell where this tumor comes from. Of course, they cannot see the surrounding because if they see the surrounding, they know where they come from. They cannot see it only based on the tumor appearance. And we found the radiologists, 3 radiologists give us a pretty random guess, meaning they cannot tell. And another study is we computed the radiomics feature of all these small tumor and train a classifier to see whether in the test set they can see where it comes from. It's also similar to the random guess. And we put it into the feature space. All this dot means one patient, one tumor, and the different color means different tumor in the organs. So we found if you cluster this radiomics feature into the 2D dimension, they are basically they're together, so they cannot tell where it's come from where. And we also ask a radiologist, is this really true across these 3 organs? They look similar, and they give us some confirm the answer, and we check the radiology report, you can see their use of the word to describe this tumor also very similar. This gives us confidence we can really generate realistic early stage tumor in the CT scan. So this is an interesting test called a Turing, visual Turing test. We mixed up the real tumor and the fake tumor together and ask a medical professional to tell which one is real, which one is fake. You can take a look at it. I'm not sure how good the screen you have, but it's pretty confusing. And the answer in this slides is tricky question. Everything is a fake tumor, actually. And having this technology is important because, as said, many type of tumor, you may not have the sufficient real example that you can annotate and use to train AI. So if you can synthesize this tumor across different organs, it can give you a good starting point to train AI or to try to annotate the real database. So that's the secret weapon number one to build this huge database. The weapon number two is called ROC curve analysis. So here the idea is to try to make the real tumor annotation faster. So usually you have a AI who have a pretty balanced sensitivity and specificity. But in this study, we try to make the AI overly sensitive. That means it will hardly miss any tumor in the human body. But um, this AI will give you a lot of false positive because it's very sensitive. How to make it sensitive? You can adjust the AI prediction threshold, or you can increase the number of a fake tumor and ask the AI to learn from a lot of fake tumor, and the AI will be really sensitive. It will treat everybody have a tumor. That's not good in the common sense, but it's very useful in this study, particularly if we want to annotate the tumor. It is because you have an AI prediction, you make it sensitive, it gives you two false positive. But usually the patient will have a radiology report, and the report will clearly tell you whether this patient is a positive or negative. So if the very sensitive AI test on a patient without any disease, you can simply remove all the predictions without any human intervention. What about the patient with disease? You have AI, you make it very sensitive. Radiologist can just remove false positive in the software, annotation software, the remove operation, just one click, then the entire annotation will be removed. So why we want the AI be sensitive? Because we found to remove one false positive, it's less than 5 seconds because it's essentially just one click. But if you want a radiologist to annotate, create the provoxel annotation from nowhere, it will take 4 to 5 minutes. So that's why ROC curve analysis is very, very important in annotating, if you want to annotate the tumor data at scale. All right, so this work have been featured in the Hopkins News. The AI and the radiologist unite to map the abdomen. And the highlight is the data set of this size would have taken experienced annotator almost 30 years to create our 1.0 data. And our team completes this task in only 3 weeks. Okay, so I already introduced how to integrate the AI into the manual annotation. Now, let's say we have a big, large scale, high quality annotated data set. We want to really focus on our mission, which is cancer detection, diagnosis, and treatment planning. Just to recap, our database now have the annotation for 16 pathology and 138 anatomical structure. It's all per voxel annotated. So this database will be really attractive for many people who have a different interest. For example, our team is particularly interested in pancreatic tumor detection. So we will use this structure to boost the performance. And this is called the Felix project at Hopkins. It's a start before, even before I joined Hopkins. It has been 8 years so far. Very, very successful project. And we demonstrate that AI trained on our database can achieve very similar performance to expert radiologist. So here we actually ask the radiologist to read the CT scan without any information like a patient history, the meditation, or anything else. Just read the CT scan to see if there's a tumor. And we also test the AI performance. And here is the result, the AI and the radiologist. We did a reader study. We have 5 senior radiologists, 2 expert radiologists, and 6 junior radiologists. And we put their performance into the ROC curve, and the red curve is AI performance. You can see the precision recall curve and the ROC curve shows that the AI can really detect the pancreatic tumor as well as the radiologist in general. We also check the tumor classification performance because after you detect it, you want to know what this tumor lesion belong to. So we have 3 types of pancreatic type. One is a PDAC, one is a cyst, one is a PNEC. And we have the confusion matrix for the 3 group of radiologists, and we have the confusion matrix on the AI performance. So overall, you can see the recall and the precision for each type of tumor. The AI can achieve not slightly, it's actually big improvement compared with radiologist. And overall accuracy, it's a 10% boost compared with the radiologist. Another interesting point is early stage tumor detection because the pancreas tumor is really 80% of them are detected at very late stage and it's not easy to treat. So we collect the early patient with a small tumor, less than 20 millimeter, and we do a reader study to compare what the radiologist can detect. Of course, it's pretty low, and the AI can detect the sensitivity is 89, and this is a result from years ago, and now I think it's 94, and the specificity is 93 for the small tumor. So it's a pretty promising result by training on huge annotated database. And we can also use the tumor segmentation and organ segmentation and vessel segmentation to do some advanced task like receptibility estimation. So usually when you detect a tumor, you want to see how it's spatial related to the connected to the vessel. If it's a surrounding vessel more than 180 degrees, then that means you cannot do the surgery. Maybe you need to send him to the chemotherapy or other treatment to shrink the tumor. Then you do the cut, right? So this is a very time-consuming and tedious work for the human, and we try to do it by AI, and we can predict the tumor staging by comparing the tumor and the SMA and SMV and further write the report, okay? Or what's the pancreas size, what's the tumor, and where it is, because we also have the subsegment of the pancreas, head, body, and tail, and what's the size of the tumor and which stage, right? So it's a pretty useful, and this information not usually written in the radiology report because it's time consuming and you know so we call it some sort of a superhuman report or enhanced human report. So to use AI to give you some more consistent information compared with human measurement, right? And further, we try to test the AI trained on the high quality diagnostic CT scan and tested on the planning CT. Planning CT usually have a low quality, and people try to plan the radiotherapy dose, and they need to segment some structure next to the tumor. So we did this collaborate with GHMI. And this is not quantified yet because we are still looking for more data to quantify it. And another reason is if you want to quantify the performance, you need a very good ground truth. But what I know is the human, even between the human, the disagreement is pretty high. So we are at the moment not able to do the quantitative study, but according to our visualization, you can see the algorithm can segment many place accurately that probably missed by a human or they are not care to segment it, right? And eventually, after all this work, we try to summarize all the image funding into the report, and we call it enhanced a AI enhanced the human report because it can really give you the accurate information more than the human-made report. And we have a narrative report to improve the patient communication. We also have the structural report to quickly let the radiologist see what is going on. And we make a table to summarize the finding, and if the patient have the demographic feature information, we'll also put there. And usually public available data set do not have this information, so we leave it blank. And another good feature is we have the key image screenshot. So other than this report, the radiologist do not need to open the CT. They can just see here how the AI detected the tumor, and the report also gives you the size and everything. So it's really make it pretty easy for the human to write a report, and they can open this report and add it on top of it if they find something wrong. So this featured on the news, say our body map really can help find the cancer early on. And currently, we have the proof of concept on the pancreatic tumor, but really we are focused on the all type of tumor. So the work is very exciting and is being done now. So I have a joke, make a joke here in the news as well. If you want to annotate this scan with so many shape, probably you need to start from the BCE time when the father of the medicine is trying to help you to annotate this. It's crazy. All right, so lastly, I want to introduce how we evaluate the AI algorithm because as a non-technical person, you might be very overloaded by the AI news. Okay, this company have a transformer, that company have the member, everything. You don't know what is really good for solving the clinical problem. And you might be overloaded by all the concepts, the foundation model, the universal model. So foundation model here is the definition is the pre-trained model, and this model may or may not be used directly for solving any task, and you need to fine-tune this model to many, many tasks. Universal model, on the other hand, they can deal with the clinical task, for example, tumor detection, and the universal means it can do multitask. So these are the definition of these two concept. And given our previous work on the huge database, we try to investigate what is really going on for the current state-of-art AI algorithm. First, I will talk about the foundation model, the pre-training. I myself work on pre-training since my PhD. I have a model genesis, that's a Mikai Award paper, and it uses self-supervised learning because in my age, there's no such wonderful database for me to train on. So I can only train the AI on the raw CT data. And that time I show it's helpful. But now self-supervised learning also very, very popular. People work on this, but keep in mind, you have another option, supervised pre-training, when the public available become bigger and bigger. So now I become a huge fan of supervised pre-training, not just because I'm a dataset provider, but we really do some serious study. So how the supervised pre-training compare with the self-supervised pre-training. So if you want to pre-train a model supervisedly, the impression will be this will be expensive because, as I said, if you want to annotate the data, will be difficult. But our study in iClear shows if you only pre-train on 20 CT scans fully annotated, it may not cost you many, and the transfer learning performance is pretty high. And this phenomenon can be scaled up. And when you get more CT scan fully annotated, the performance will dramatically improve. On the other hand, the self-supervised learning, because it's only learned from the raw data, the learning efficiency is very, very low because the model essentially do not know what to learn. So we find that even if you use 5,000 raw CT data and you use so many GPU power hour, the performance, first, the increase is not many, and the performance not as high as the supervised pre-training. So we asked the question in our paper, how well do model pre-trained on 25,000 fully annotated CT scan transfer to medical imaging task? And the answer is, of course, I really like it. If you use our pre-trained model, it can essentially cut half of the annotation cost, whatever task you are interested in the transfer learning. And we also released the benchmark. We put all the very famous pre-training model into one place and let you to test how good they are. And Supreme supervised pre-training is our model. It's pretty strong compared with all this foundation model. Second, we wanted to know what is the best architecture for universal model. So instead of what people usually do, so they will write a paper say, oh, we propose a unit plus plus is better than any architecture in the world, and you see a lot of this paper. So we don't want to do that because it's pretty confusing. We try to invite the inventor of each famous AI algorithm and ask them to train on our database. And the Hawkins team as the third party to independently run their code on our internal database and to really report their performance instead of the table you see in their individual paper. So this is a very tough benchmark, and these are current team we invited, and the results have been published last year in the Neuros, and we do have a lot of winner. So that means all these architecture is pretty good, and of course I didn't put any architecture developed from our group because it's unfair to other people. So we find the first observation is NUNet framework is always very strong. And the transformer not perform as well as the CNN-based method. And there are other very useful insight, like depends on the class you are segmenting, the patient population you are dealing with. So if you are interested, you can always check this paper. And we also release all the AI model to the public with their permission. And this can benefit you if you want to do this work. And so many teams agree to help us to benchmark their AI because they are the only one, in my opinion, who want their AI algorithm to be successful among other people. So this is our motivation. We want to have a real touchstone benchmark to able to tell the non-technical people what is the real state of the art of the medical artificial intelligence, right? So we plan to make this touchstone longer term. So I would be really appreciate if you can forward this message to the colleague who might find this interesting or who might want their brilliant AI algorithm to be visible because so many paper about algorithm recent days. So we are here to help you evaluate your algorithm in the holdout set. So quick summary of what I have been talking. We have the body map project and all this data set creation, this AI benchmark or the AI creation is really to solve the clinical problem, to detect the cancer earlier and the classify them better and treat them better. So we are in this area, we really need a lot of collaboration from different institutions that support us to really do the quantitative study, not only pancreatic tumor, but also we are dealing with the 16 type of tumor in the abdomen region. So welcome to join this effort. And as a professional like promise, we released all the data set 1.0, 1.1, 2.0 under a non-commercial license so that all the researchers can benefit from this. And if you want to, if you find it really useful for your commercial purpose product, we can also talk about it. And all these data set can be downloaded from the website. And we also have a Twitter account that visualize and tell you the individual patient, of course, is a de-identified patient in our database and see what is going on in this patient. It's a video, and we update it in a weekly basis to, to commune with other people who might be interested in our body map project. All right, so I will stop here. Thank you very much for your attention and the time. And I really want to thank a lot of colleagues who make this huge project happen and being running so successfully. Alan, you are is a very good advisor to, make this project even more successful. All right, thank you very much.